Yeah, thanks very much. So I don't normally get to speak in public, and you might be about to spend the next 20 minutes working out why. So I've been invited along to talk about not doing CPR. I don't want to ruin the atmosphere because CPR is a hugely important part of our work. I have a colleague at work who ran the Edinburgh Marathon last year, and when I texted him to say, how did you get on? He said, I had a VF cardiac arrest at kilometre 11. I did call him a twat, which I guess wasn't the most friendly. If you're going to have a cardiac arrest, do it when you're 800 metres away from Stephen Short, which is what he did. So he got very prompt defibrillation with some bystander CPR. And I'm delighted to say that he is absolutely back to his normal self. So there is clearly some real value in what we do. But unless you're going to die from catastrophic disruptive trauma, the last event in your life will be that your heart stops. And so what we need to do is be able to work out when someone's heart has stopped and needs to be restarted, and when someone's heart has stopped and allow a natural death. And so I feel a little bit like this. So I've been asked to come and speak to you about not doing what we're spending a day talking about doing. So we'll see how we get on. So I'm from Middlesbrough, not the posh city of Newcastle where the other Gareth is from. So I'm not particularly highbrow, which is why I say I've got a passing interest in the science of medicine. It just keeps me away from the GMC. But I do want to talk to you a little bit about philosophy. You weren't expecting that, were you, Gareth? So Auguste Comte is a 19th century French philosopher. I'm not going to bore you with what he said, but he's revered as the father of scientific philosophy. And he talked about positivism. And the first stage of positivism is the theological state. Chemistry, physics, biology, they couldn't have just been invented. Somebody must have invented them. So there's the theological state. And we believe in supernatural agents, and we're just taught what our fathers and forefathers or mothers and foremothers taught us. And that's what we do. So we always do what we've always done. And then he described the maturing process into that metaphysical state where we start asking, really? Is that exactly what's happening? And then we move into the positive stage where we give up on that absolute truth and we start to head towards discovery. And so if you create an overlay of CPR, the theological state is this is when to do CPR and this is how to do CPR. But anyone that's done CPR, either as a bystander or as a professional, must have spent some time thinking, is this absolutely right for this person at this time? So we then move into that positive stage of saying it's okay not to resuscitate people. Some people, their heart has stopped because they've died and they don't need resuscitation. What they need is a natural death. And the King's Fund produced a document about patients' preferences. And so I've kind of summarized, I think it's 112 pages into one Venn diagram, which I was quite proud of. But essentially what we need to do is we need to pull together the evidence base. Will CPR work? The patient context, does the patient need CPR? And the patient preference, does the patient want CPR? And so the sweet spot that we need to get to is where all of these things overlap. So I want to introduce you to three people. So in 1932, identical triplets were born. They were called Catherine, Patricia, and Roseanne. So if you ever wondered what CPR stands for, that's what it stands for. So this is Catherine. So Catherine is a 92-year-old lady. She's got severe vascular dementia. She's non-verbal. She's got heart failure, diabetes, chronic back pain. She has a catheter and often will have UTIs associated with that catheter. She's got an incredibly caring family. And she has a DNA CPR certificate in place. Someone's had that conversation, has decided that CPR when her heart stops is not in her best interests. She's not able to express that, but the family have had it discussed with them, and they are advocating on her behalf and saying, my mum would not wanted to live like this. She would definitely not want CPR. So we've got a DNA CPR in place. So I want to introduce you to Patricia. I did say they were identical. Patricia is a 92-year-old lady who has severe vascular dementia, must be genetic, non-verbal, heart failure, type 2 diabetes, chronic back pain, catheter-associated UTIs, and has a very caring family. She has no DNA CPR in place. No one's had the conversation, no one's found the time, no one's taken the time to explore whether this would be the right thing should Patricia get into the situation where her heart has stopped. And the third sister, Roseanne. Roseanne, not unsurprisingly, is a 92-year-old lady who has vascular dementia, non-verbal heart failure, type 2 diabetes with back pain and associated UTIs. She has a very caring family, and there is no DNA CPR in place. She is for full escalation. If anything happens to Roseanne, we are to start CPR, take her to the hospital, into resus, off to ITU. So that's the family choice. Unfortunately, at the same time, they all become unresponsive and they're all found to be pulseless. Who would have thought it? So, who gets CPR? Well, I would like to say Catherine doesn't get CPR, but we know that there's a small chance that Catherine will get CPR because we might not know where her DNA CPR certificate is. She might have a carer that's with her that doesn't know the full story. So there is a small chance that Catherine will get CPR. But on the whole, we would like to think that Catherine probably won't be offered CPR and will be allowed a natural death. So Patricia, we arrive at Patricia's house and she's in cardiac arrest. And does she get CPR? So this was the lady that we just hadn't had that conversation with. So maybe it's I, maybe it's not. Let's see what the weather's like on that day. And then finally, we have Roseanne. And I can guarantee you that there's a pretty good chance that Roseanne will get CPR. So in her dying moments, in her last days, last hours, last minutes, last seconds, she will be having eye gels, cardiac massage, and all the rest of it. So the question is, which of those patients would benefit from CPR? And the answer is probably none of them. But the bigger question is, who do we feel confident in not offering CPR to? And the answer is, Catherine, yes, certificate, we like certificate, signed, dated, that's good. Patricia, that's a difficult one. Roseanne, family wants CPR, let's just crack on. And I want to bring the idea of what we can achieve by CPR. And this is not scientific, as Gareth has told you. That is not my bag. So please don't quote this as some kind of seminal work in the resuscitation space, because it isn't. What I'd like you to do is think that CPR, the best it can get, is that you can return the patient to what they were like 5 minutes before their heart stopped. So for those of you that don't know, the top picture is Fabrice Muamba, so midfielder for Bolton Wanderers, playing at White Hart Lane against Spurs, and has a cardiac arrest. 5 minutes before his cardiac arrest, he was running around the pitch. The best that you can do is getting him running around a football pitch again. Who wouldn't want that? That is absolutely the best that you can get, and that is what we're all here to achieve. Next patient is a man in his late 60s who's having a myocardial infarction, and he's probably already got a little bit of myocardial damage. He's probably already got a little bit of irreversibility, but when his heart stops, the best that you're going to get him is pretty good. So he's probably going to have an intact brain because there was nothing wrong with his brain 5 minutes before his heart stopped. And if you can deliver effective and good quality CPR, then you will maintain that cerebral perfusion and you will keep his brain pretty good. And if you're successful in resuscitation, he might have a little bit of angina, he might have a little bit of breathlessness and exertion, but you are going to get him back to 5 minutes before his heart stopped while he was having his MI. I'm just going to apologise, I can't remember whether that's the picture of Catherine, Patricia or Roseanne. So just forgive me, I think it's Patricia. So Patricia, the best that you can get her with CPR, defibrillation, interventions with the airway and the other stuff that people do. I'm a GP, by the way, so it's really good that there are people out there doing that stuff. So the best that you can get Patricia is severe vascular dementia, non-verbal, chronic back pain, UTIs, loving family. That's the best that you can do. So how do you navigate between Catherine, where we've got a lot of confidence that we're not going to do CPR, between Patricia, where we're not really sure what we should be doing, and between Roseanne, who the family want full escalation for. So I've gone to our regulators. So I'm regulated, developed and controlled by the Laboratoire Garnier. I am regulated by the GMC. Some of us in the room will be regulated by the NMC, and I guess the majority in the room will be regulated by the HCPC. So this is what the GMC says. I'm not very proud of the GMC sometimes with some of the moves they make, but I am proud of the GMC today because they say in cases where you assess that such treatment is unlikely to be clinically appropriate, you may conclude that CPR should not be attempted. So I can stand as a registrant of the GMC in front of Catherine, Patricia, and Roseanne and say, stop. Why do I do that? Well, you know it's not because I'm cleverer than you, because Gareth has highlighted that I'm not, which was using my words to do so, which is absolutely grand. So it's not because I'm cleverer. And looking around the room, there are a few of you that are maybe my age. So it's not that I've been doing it longer. It is purely because I have the confidence not to offer CPR to Catherine, Patricia, or Roseanne. When you look at the Nursing and Midwifery Council, they say where no decision about CPR has been made, there should be a presumption in favour of CPR. And it is a big ask to not do CPR for 15 minutes and then discover you should have done CPR, because that's going to be challenging. So the NMC are a little bit in the grey area, but they further clarify by saying this does not mean indiscriminate application of CPR that is of no benefit and not in a person's best interests. I went to the HCPC website. I was no affy impressed. So it does tell you not to sleep with your patients. And that is a good thing, so anyone thinking about it, just beware. It's on their website. But the HCPC says, as a health and care professional, you must promote and protect the interests of service users and carers. That's it. I did spend a bit of time going through their website, going through their information, their PDFs and their attachments, and I couldn't find anything that made me feel confident that they want to put it out there explicitly. That doesn't mean you can't imply, and that's what I'm doing here. I'm implying that that sentence says, if you don't think a patient would benefit from CPR, then you give them CPR. For those of you that work with the Scottish Ambulance Service, I would like to say that I am very proud of working for the Scottish Ambulance Service, and I know pride is a deadly sin, but it's true, and the reason for that is it's a developing organisation, and we have some underlying organisational strength. We have some real strength. Some of it is pretty similar to stuff in other parts of the country or the world. Other bits are pretty out there in terms of how we're supporting and developing pathways for our patients and for our healthcare professionals to use. And it is worth remembering that we have a very good organised team in the palliative and end-of-life care situation. Now, they're not going to answer your call when you're sitting next to the patient, but they do offer an awful lot of good quality training and experience when it comes to working out when it's the right thing to do this or when it's the right thing to do that. We have a really good pathways team, and a particular focus of that is frailty. Frailty should not be a discriminator, but it is a descriptor. So we shouldn't be saying because someone's frail, we're only doing this, but we should be using frailty as a context. We know that frail people are less likely to survive CPR intact than non-frail people. And when you speak to most frail people, and as a GP, I speak to a lot of frail people, they're usually very clear in what they want and what they don't want. We use realistic medicine and the pillars of realistic medicine, so we try and do things pretty similarly and avoid variation. We try to reduce harm and waste, and I think it is okay to talk about plastic waste because we create an awful lot of it, particularly when we're doing CPR. It's about being patient-centered, so putting the patient at the center of everything you do, and then shared decisions, so sharing that decision and sharing the risk of that decision with other people in the room, family members. And we have an integrated clinical hub, which for those of you that are out on the road and don't know, it's essentially an organisation that's kind of filtering off jobs that probably don't need us to respond to, and we can look for alternatives. But if we do respond, we're there. We've got really experienced paramedics and nurses. We've got advanced paramedics and advanced practice nurses, and we've got some GPs, and they will chat through things with you. And so I'm just going to leave you with a final message. And I really do want you to look at it through this lens, if not all day, just for this 20 minutes. As you race to that purple call, consider yourself not as a resuscitator, but as a well-trained and confident advocate. My name's Gareth Evans, and I endorse this message.